All right, we have our final Tier 3 question and answer session, and let's get started. So we have case 1, which has a fairly lengthy introduction. 28-year-old patient with 3 prior pregnancies, all to term, presents pregnant at approximately 12 weeks gestation. Her obstetrician orders routine blood work. Her antibody screen shows no antibodies. So let's go antibodies. We know the age is important. The patient then presents to the emergency department after a motor vehicle accident with heavy abdominal and vaginal bleeding. So we know bleeding is important. A massive hemorrhage protocol is activated and the mother is taken to the OR for an exploratory laparotomy and emergency C-section. Her current hemoglobin is 50 and is dropping. You have a historical OPAUSE that's on file, and you receive the first set of tubes as the transporter shows up to pick up the first cooler. So I've circled the important parts as we go through. 28-year-old, so less than 45 years of age, no alloantibodies present that we know of. The patient's actively bleeding. The hemoglobin is 50 and dropping, and they have a historical OPAUSE. So you issue your first cooler, and of course your first cooler is going to be O-neg because she's less than 45. And as far as you know, she still can have children. You notice that there's an outside hospital screening calling for anti-JKA. What are your next steps? Assume that you're at a large blood bank with many units on hand. You can recall the cooler and only issue JKA negative units. You can leave the first cooler and only stock JKA negative units for the future coolers. Continue with the MHP without screening for JKA and phenotype the units after the bleeding event is done. Stop any transfusions from occurring until the alloantibody can be identified with an antibody panel. So first and foremost, this is out because the patient's actively bleeding and we know that we need to move forward without waiting. So either if there is a JKA in there and we can't quite tell if it's there, you don't stop for that reason. You would also, for that same reason, wouldn't recall the cooler because they need the blood. And you don't even have any units on hand you could swap out even if you wanted to. So remember, saving their life with a red cell transfusion is more important than trying to recall it and doing the screening of your inventory. So then we have B and C, where you can leave the first cooler and only stock JKA negative units in the future coolers. This is going to be massively difficult because JKA is only about 25%, JKA negative units are about 25%, and so you're going to have a hard time finding enough units to stock your MHP, and to take the time to do it means you're going to probably have to delay release of your future coolers. So that's out as well. That leaves us with C. Continue with MHP without screening, and then after the fact, you'll take the segments and you'll screen them for JKA, and you'll let them know that there were some incompatible units and that they need to monitor for hemolysis. So this patient's bleeding pretty profusely because we have an MHP that's now in cooler 5. Then you receive a call that blood's no longer needed, the mom's out of the OR and recovering, and the ABO and antibody ID are now done. So our forward typing looks like a group O. Our reverse typing looks like we have a missing antibody, and our RH type looks good at 3 and 4 plus. And based on the historical, we would suspect this is what's discrepant, right? Because the mom should have anti-A and anti-B in her plasma because she is historically O positive. So would you expect the ABO type on a new sample after the 5? So this is, kind of in the midst of all of this. So this isn't quite at number 5 yet. Would you expect the ABO to show mixed field, RH type to show mixed field, the ABO and RH types to show mixed field, or none because the patient's receiving matched units? We know this isn't true because as a mom that was getting the MHP done, and while we were running testing, she would have gotten O-neg just based on the knowledge that she's less than 45 and obviously is pregnant, so she has childbearing potential, and we don't want her to form ATD. We also know that her ABO type should not demonstrate mixed field because she's receiving group O and she is group O. So now we're stuck between B and C, and of course we know that this can't be true because A isn't true. So the RH may show mixed field because she's receiving RH neg and she is RH pos. So the RBCs together may give a mixed field reactivity given enough time and enough units. Now, surprisingly, in this particular case, we don't have mixed field. So here we have an antibody ID panel, and let's take a look at the reactivity that's observed. It's pretty much 1 plus with cells 1 and 2, cell 4, cell 5, 6, and then the auto control. If we just do a quick rule in, rule out, it looks like we have an ATD based on what we have. And then, of course, we weren't sure about the JK because it was historical, and it actually is possible because it matches up with these first two. Everything else looks like it can be ruled out for the most part, except for the anti-N and potentially a Lutheran A. But otherwise, it looks like it's matching with an anti-D and, of course, the possible anti-JKA. And if we look down here with D negative units that are JKA pos, we're not really seeing reactivity. So if you were to ask what the most likely antibody that we're observing in all of this is, the one that matches closely is anti-D. Okay, so question 4 is, based on the antibody panel given, including the elute performed, would you expect this to be an allo or an autoantibody? And this is a bit of a tricky question, so I wouldn't be expected if people are split on it. So we have an antibody that looks like it's an anti-D. In the presence of an auto, the anti-D is 1 plus and the auto is 1 plus. So it's possible that this is an autoantibody, just to make some specificity. When we do the elute, it looks like it matches with an anti-D again. So then the question becomes, still, is this an auto or an allo? Now tie this back to the fact that the patient has been typed as Rh positive, right? We typed her with 2 different reagents. We have a historical that she's Rh positive. So in this particular case, you may argue that just based on what we see, this is possible on auto, but I would not fault you if you were to call this an allo because of the fact that you might suspect maybe she is a non-white individual and therefore her Rh positive could be a variant or something of the sort. So when you see an anti-D in a pregnant patient that is Rh positive, you should immediately think about one particular antibody, and the text thought about it in this case because they went after a DTT treatment. And DTT should theoretically destroy the antigen that this antibody goes against that can look like an anti-D. So let's take a look. They did it, and no change, no change, no change, no change, no change. Even the auto control doesn't change. So it doesn't look like it's this particular antigen. And so when we're looking at this, we know that this is not an anti-K. It doesn't have the specificity. It's not a NOPS, and it's not a Lutheran A. So what we're talking about here is a LW antigen. LWs can look like, anti-LWs can look like anti-Ds, and they can be differentiated by the fact that they're destroyed by DTT, whereas RHD is not. And so the texts were trying to prove that this was an autoantibody rather than an alloantibody. And this is where serology can trick you up, as you'll see later on, because the possible anti-D would have been potentially chalked up as to an auto if more workup weren't done. So the LW antigen is named after its discoverers, the Lansdiner and Wiener. So the L, the W. It's a 3-antigen system, LWA, LWB, and LWAB, and it's part of the ICAM adhesion family. So ICAMs help cells adhere to the vascular system and to tissue before they kind of migrate through. LW A-neg, B-neg is very, very rare. It's only been identified, I believe, in 4 individuals. The first one actually was found in Canada. Her name is Mrs. Big, and she's pretty much in all the books, including Marion Reed. Antigen density is increased when in Rh positive individuals. So as your D antigen increases, your LW antigen appears to increase as well. So even though there are 2 separate antigens, the strength of the D influences the LW. So that means that Rh neg individuals have lower LW, and therefore when the reactivity goes with an Rh neg, you may attribute it to an anti-D when really it's just the LW not reacting. Now, there's a key difference between Rh neg cells in adults and neonates versus LW in adults and neonates. So cord cells express similar amounts of LW compared to anti-D. So in a cord cell, if you have an Rh neg, the person's D neg, right? If they're Rh pos, D pos. However, When you're talking about LW, they're LW positive either way. And it's because the antigens on the surface are expressed in younger red blood cells, or excuse me, in cord cells, and therefore they can be detected there. So if you do your reactivity with cord cells, you may notice that it reacts with both Rh positive and negative cord cells, which would be your LW, and it's sensitive to DTT, again being LW compared to Rh, an anti-D. It's pretty much resistant to all enzymes except pronase, and as I said, it is sensitive to DTT. This antibody is predominantly IgG based, and it can actually be seen in pregnancy and cancer. So the antigen can be suppressed. In cancer, there are various malignancies, predominantly in the bone marrow, that can cause suppression of LW, and in pregnancy, you can get temporary suppression of the LW. And as a result, you actually can see an anti-LW form in these particular instances. And when that happens, you have to also see a positive DAT. It's thought that anti-LW is the preceding antibody to anti-D. So there was a study done of just, I think, 30 patients where they looked at anti-D formation in men that were being exposed to Rh positive red cells. And what they found was before the anti-D ever formed, an anti-LW was seen. And most times the anti-LW would then disappear just as the anti-D was forming. And so this, I haven't seen any other studies proving this over time, or at least I should say more recent studies showing this, but it's a theory that anti-LW precedes anti-D. There's no known hemolytic potential of cross-matching compatible blood. So if you were to give an incompatible unit against an anti-LW A, B, or AB, there really should be no hemolytic consequence or hemolysis as a result of this. And Mrs. Big actually had 3 children. The third one was a Rh negative individual, and this child actually had almost no HDFN. So it's not really known to cause any issues. However, you can imagine in Mrs. Big, she has an anti-LWAB, it pretty much reacts with all cells, and so it's more of a nuisance than anything else. So you have to DTT treat the cells in order to look past it. So based on what we talked about, this question is asking about if the ruled out antibody was present with DTT in cord cells, what reactivity would you expect? So essentially, if there was an anti-LW, what would you expect there to be? Well, we know it would be sensitive to DTT, so these last two have to be out. And we know that Rh positive and negative cord cells will react equally with an LW antibody, and therefore is the answer, because B states that there's no reactivity with cord cells. So let's recap. We did work because there appeared to be an anti-D in an Rh positive individual. We showed that it was not an LW. We have a history of an anti-JKA in this individual. So we now have to match. What are we going to do when you talk to your medical director? Well, since we haven't been able to prove or disprove the JKA, you would of course match for it. And because the only evidence that we have is it's an anti-D, right? And we don't know if it's an L or an auto, we're going to do our best to try to match for it. So we know that it's not an LW. So we know that we can't treat the patient as if they have an LW because it's not there. And we know, again, no LW, no LW. So now we know that we have to include the D in the JKA, so it can't just be A or C, leaving us with D. We're going to match for both the JKA and the anti-D until we can get to the bottom of what's going on. And this is the reason why I said that serology can really trip you up sometimes if you aren't paying close enough attention or you aren't willing to go after it. So remember, anti-D in an Rh positive individual who's pregnant. Most often people would chalk this up to an anti-LW and not really do much more. However, we know that there's something off going on. We also had an auto control that was positive, right? That was equal to our anti-D reactivity, which would make you suspect it's possibly an auto anti-D, which does happen in pregnancy, right? You can see auto anti-D not infrequently in pregnancy, especially if someone has an underlying condition. So it's good that this one was tracked down because it turns out it's a DAO4 or a T5, D type 5. So the problem is that these do have the potential of forming anti-D, and you do want to match and give Rh negative blood, and treat them as if they're Rh negative and match for Rh negative blood. So in this case, you would expect hemolysis if an anti-D were present. This is a real anti-D that you don't want to mess with. So I want to give you a little bit of background on the Dow cluster. The Dow cluster is an interesting one because it all starts with the Dow zero molecularly, which has a 1136C to a T mutation, and it occurs here in the Rh. So this is the Rh protein here that we're looking at in this box, and then the depictions are the different Dows. What's important to note is that in order to be anything other than a Dow zero, you have to be a Dow zero. So Dow zero is kind of the parent, and then it branches out into the other Dows as the other variants pick up. So you can see Dow 1 has this variant, Dow 2 has the variant, Dow 3 has the variant, Dow 4 has the variant. And then they're layered on with others. So for example, Dow 2 has 2 additional variants, here and here. The Dow 4 has 1 variant, right here. Dow 3 has 1 variant again. And then we've got the Dow 1, which again has its own variant. So the Dow cluster has the potential of forming anti-D. And so you want to be very careful of it. It's also important to note that our ID core XT does not detect the Dow cluster. So it's our quote common genotyping panel. So if you do a common panel and you get the common antigens back and it says that the patient's Rh positive, as our panel did on this patient, it's because it misses the SNPs involved with the Dow cluster. So they can be called Rh positive even when they should be treated as Rh negative. And serologically, they'll appear Rh positive for the most part, unless you happen to get a monoclonal that's able to catch, or that will not bind to the epitope of one of the Dow clusters and then give you no agglutination. So overall, we know that the anti-D is real. It is not an allo. It is not an auto. It's an allo antibody. We also know that we have an allo anti-JKA as well. So we would give Rh negative blood and JKA negative blood in order to protect this patient from causing any future hemolysis. So our second case is also a pregnancy case. We have an 18-year-old pregnant patient presenting for routine blood work. Your blood bank receives a sample for ABO identification and an antibody screen. So let's take a look at the ABO ID. So our forward typing looks like a group O. Our reverse typing looks like a group O, right? So we have no agglutination with anti-B and anti-B, anti-A and anti-B. And our reverse typing shows that it's binding to group A1 and B cells. And then our Rh typing is negative with 2 RHD monoclonal reagents. Our DAT is negative by polyspecific reagent, and let's look at our antibody ID. It looks as if, based on the highlights, we might have an anti-D, and our autocontrol is 3+. They also did it in saline, so immediate spin 37 IAT, immediate spin and 37 show no agglutination. And at saline IAT, it looks like we also have the same 2+, 2+, 2+ and no agglutination, and 2+ and auto control. So if you want to resolve the auto versus allo antibody that may be there, the auto versus allo antibody that may be there, what would you do next? DTT treat, wash, increase incubation time of the red cells, or enzyme treat the red cells? Well, we know that the main way of distinguishing between auto and allo is actually enzyme treatment. DTT will not get rid of an auto or enhance it. Washing the red cells won't do anything because it's in the plasma, and increasing the incubation time isn't as effective as doing an enzyme treatment. So let's look at what they did. So they did Fison, and it went up to 3+ now. Still no agglutination with cell 3. Cell 4 has 3+ reactivity. So it enhanced the reactivity, but didn't give us pan-reactivity. If this were a true auto, we would expect, 4+, 4+, 4+, 4+, and then the auto would be 4+ as well. But that's not what we're seeing. So this looks like a true allo antibody. So now the question is, just based on what we've given you, an anti-big C or D, which of the following could it possibly be, based on the fact that there's splicing. There are other potential antibodies. For example, it could be a JKB. It could also be a big K, right? It could be a bunch of different things, but just based on these two antibodies, what's possible? Well, if we look at this, cell 1, 2, and 4 are positive, so it's possible that it could be an anti-D or an anti-big C. So the answer would be not auto, right, because we've shown that it's not auto, but B, allo anti-big C or big D. So now the technologists know that there are allo antibodies in this pregnant individual, and they're trying to go through and rule out as many of the antibodies as they can and also identify based on specificity. And you can see that they think there's an anti-D and an anti-big C. However, because both of these are present, they're now stuck because they need to rule on a particular antibody, and it requires a rare cell, which is why they pulled this out. So the question now is, what are they using the little r double prime to rule out? So little r double prime is little c big E, little c big E. And in this particular case, they're trying to rule out the big E because the D and the C make it difficult to find a cell that will not cross-react, right? So if they tried to do R2, they're going to have to deal with the anti-D. And of course, trying to do an RZ or an RO is going to, an RZ or an RY is going to be difficult as well, just based on the rarity of it. So here they're kind of finishing up their rule outs, and we know that we see an anti-big C and an anti-D that are reacting independent of one another. So the question becomes, what possible antibody are we going to have to worry about? Remembering, this is a pregnant patient. So whenever you have a pregnant patient, or really a woman in general, you want to make sure you chase down an anti-G. The reason is, anti-G is different than your anti-D and C, and it will therefore affect your Rh immunoglobulin administration. So before we get started on the question, an anti-G essentially identifies an epitope that's on both the D and the big C. And so therefore, if you express the big C or the D, it'll bind to either of them. And it can make it look like two separate antibodies, when really it's one. And you can have an anti-G without having an anti-D or big C. And if you only have an anti-G, you would give Rh immunoglobulin, Rhd immunoglobulin, I should say, because they can still have the potential of forming anti-D. Now, it's also possible you have an anti-G, anti-D, and an anti-C, in which case you wouldn't give Rhd immunoglobulin as a result. So now this question is asking about if you were to do an R2-R2 alloabsorption, and if then anti-G, D, and C were present, what antibody would be left in the plasma versus the eluate? So let's make a little table here to help ourselves out. So we did an R2 adsorption. So this is a D, C, big E, D, C, big E, which means that if you added this to the patient's plasma, and then you checked, you'd look at the alloabsorbed plasma, and there should be what left versus the eluate. So the alloabsorbed plasma will only have the anti-big C left over because it removes the anti-D and the G because there's a D present, right? Which means that in the eluate, you should be able to see an anti-D and an anti-G, and you can actually detect the anti-G with your big C positive cells, right? Because it should react with that. So that gives us our answer of an anti-big C, and in the eluate, an anti-D and a G. So here we're asking you to do the same thing. Little r prime, little r, which would be a big C, little e, little c, little e. So the question is, what are we going to alloabsorb out? And we're adding this to the patient's plasma, and we're worried about an anti-G anti-big C, anti-D. So if we look at the alloabsorbed plasma, and we look at the eluate, the alloabsorbed plasma will pull out the anti-G and the anti-big C. The reason why the G comes out is because it's C positive and it'll bind that. The eluate will have an anti-D left over. The way you distinguish the anti-G in this case is you re-expose it to an to a D positive little c little e cell, essentially, and it should still react. So our answer in this particular case is we'd have a D in the plasma and a C and a G in the eluate. So let's do those mental jumping jacks one more time here. So we have our two cells that we're going to use for alloabsorption, the R2 and the little r prime little r. And we're asking what antibodies are left over when we alloabsorb them. So we have alloabsorbed with an R2. Okay, so that is a phenotype that would look like this, which would mean that we remove out an anti-G and an anti-D, and we should have left over an anti-C if it's here, and we've got a big C positive cell, and we see nothing. So there is no anti-C present. Let's do this one more time. So this little r prime little r is going to be big C, my handwriting's off. Big C little e, little c little e, and therefore it would pull out an anti-G and an anti-big C, leaving behind an anti-D, and sure enough, we see an anti-D now. So now the mental jumping jacks continue. We know for sure we have an anti-D, right? So A can't be true, and we know we don't have an anti-C, big C, so that can't be true and that can't be true, leaving us with B. And the reason why we come to that conclusion is, if we look back to this panel, this top panel here, we have reactivity with a big C cell that you would not expect if there were only an anti-D, right? If there were only an anti-D, we would not see big C specificity. And it's because there's a mixed in anti-G. So you actually don't even need the eluates in this case. You can just use the three panels to kind of come to your conclusion. And now remember what I said. If you have an anti-G, it does not mean that you can't produce an anti-D and an anti-C on top of it, right? So if we had only identified an anti-G, this patient would get RHIG. If the patient has anti-D and G, well, they've already formed the anti-D and they don't need the RHIG. So because we have an anti-D and we have an anti-G, the patient actually doesn't need it because they have the anti-D. And remember, anti-G does not mean you have an anti-D. So if you had anti-G as in golf, you would give them Rh immunoglobulin. So that brings us to the end. Thank you, everyone. Hopefully you found this helpful, and if this format works better than the wet workshop, we may convert to a dry workshop in the future. So thank you for watching, and I'll see you guys at the live session.